will request Dr. Srijana Adhikari. She will be giving the keynote address dealing with inflammation in pediatric cataract surgery. Dr. Srijana Adhikari is professor and head department of pediatric ophthalmology and strabismus at Tilganga Institute of Ophthalmology, Kathmandu. She did her fellowship at Storm Eye Institute, South Carolina. I also did from the same place. I was there for 2 years.
With Dr. Abby.
With
Yes.
Dr. David Apple and Dr. Amy Wilson.
Yes.
And she has a lot of, I think, publication, 50 publication, and she's current president of Nepal Pediatric Ophthalmology and Strabismus Society. So please go ahead with keynote address.
Thank you so much, Dr. Jagat Ram and the organizing committee for this invitation. I would like to talk a little bit about how we deal with the inflammations in pediatric cataract surgery. There is no conflict of interest. So inflammations after the pediatric cataract surgery is as challenging as the decision on timing of surgery, to put or not to put IOL. That's what we just discussed, and the power calculations, visual rehabilitations, and the surgery itself. So we all talk about all these things, but the inflammations that we have to deal with the pediatric cataract surgery is less talked about. And sometimes, even after an uneventful, excellent cataract surgery, at times it gives a headache for many weeks for the pediatric cataract surgeons. So why the inflammation is more in pediatric cataract, and why we are always worried about that? Because there are some studies that show that even without the cataracts, even without the surgery, the inflammatory indicators are more in the children with the pediatric cataracts than the adult ones. And also after the pediatric cataract surgery, also it is more in the pediatric age group than in the other age group. So even without the surgery, the inflammatory indicators are very high. So these all leads to the very high inflammatory reactions in the pediatric patients after the surgery. And there are some other causes also, like immature blood-aqueous barrier in the children, and of course one very important, poor adherence to the medications, and exposure of the lens protein to the rest of the ocular structures. Sometimes even if the smaller remaining cortex, cortical matter in the pediatric cataract surgery, it leads to a lot of inflammations compared to the adult cataracts. And remaining viscoelastic materials, of course, and intraocular lens implantation. It has shown that with or without putting the IOL, the studies have shown that the inflammation is more in the pseudophakic groups. So there are different grades of inflammations that can occur, like one is antechamber, simple antechamber reactions to toxic anterior syndrome, and then after that fibrinous exudates and membranes, and which is the most severe one is the endophthalmitis. So we at times face all these inflammations in pediatric cataract surgeries. And posterior membranes and PCOs, usually I feel that it's very easily taken care of, because if you do very nice posterior capsulotomy and anterior vitrectomy, usually PCOs are not very frequent, but the anterior chamber reactions and fibrinous exudates are more frequent, and it is very difficult to deal with those reactions after the pediatric cataract surgery. And more often it leads to pupillary block, anterior synechia, raised ICP, raised IOP. So these are all the things that leads to after the pediatric cataract if there is a lot of inflammation. So and what is the risk of increased inflammations? Of course, the juvenile idiopathic arthritis associated cataracts, uveitic associated cataracts, traumatic cataracts, post-endophthalmitis cataracts, or aphakia if after the endophthalmitis, if it has lensectomy has been done, and post-vitrectomy cataract. In those aphakia or cataract, in those cases, if we have to do the surgery later, then these are the increased risk of inflammations. So we had a small a study done in our institute, and which showed that the complications after the pediatric cataract surgery, the common was the fibrin one. We got around 19% of the cases of the pediatric cataracts having some kind of complications, and on the fourth post-operative day, the highest, the fibrinous reactions were highest in the fourth post-operative day. So there were other associated factors like the age more than 4 years, and then accompanying parents when the mother was accompanying the child, and then the socioeconomic status, lower socioeconomic status were associated with the inflammations or more complications. That also shows that adherence to the drug is also very much important in pediatric cataract surgery. So how to approach or deal with the inflammations in pediatric cataract surgery? There are different stages like pre, intra, and post. All these steps are equally important. In pre-operative, we have to find out a very good history, if there is any associated systemic illnesses or not, anterior segment examinations, if there is any associated other comorbidities are present or not, and of course posterior segment evaluation should also be done. And GIA is cataract is very frequent in GIA, and we commonly encounter this problem. And the risk factors in GIA for the development of the cataract is posterior synechia, and then the corticosteroid itself, due to the inflammations or corticosteroid, both can give rise to the cataract formations, and then active ongoing inflammations, of course. So GI we have to deal with very cautiously, and perioperative period is very important. The inflammation should be reduced, and at least there is 3 months of inflammation free period before we should intervene in the GI cases. And then intraoperative also less manipulations. The synecholysis should be done very well prior to the cataract extractions, and we can use viscoelastics, whether for the dissections of the synechia, whether to implant or not to implant. In these cases, we have to do clinical decisions. Sometimes the inflammations is so intense that it's better not to put the intraocular lenses. And then comorbid pathologies also has to be dealt with. So, and then the corticosteroid, of course. Then the post-operative period is also important, because there are so many post-operative inflammations are associated with this, like CME, epiretinal membranes, hypotony, and then that's why escalations of the immunosuppressive agents should be done, and it has to be very close collaborations with the rheumatologist. And the tapering is very, very important in these kind of situations where the drugs should be tapered very cautiously, the steroid, not like the other usual cataracts. And the traumatic cataract now is also a very poses the high risk of inflammations post-operatively. There can be injuries, lens ruptures, bitter graft, anything can happen in post-traumatic cataract. So and that's why we have to, at the time of repair, if there is an open globe injury, all the lens materials that should always be removed very thoroughly, so as to prevent the adhesions later. And the secondary IOL can be kept usually 6 weeks after the primary repair, along with the removal of the sutures. So we cannot wait more than 6 weeks because there is a chance of amblyopia. But in older children, we can consider waiting a little longer. And if there is no bag or IOL, the scleral fixation can be an option. But if the smaller children, no bag, no IOL, then leave the child aphakic and then do the visual rehabilitation accordingly. Of course, contact lens is an option, but for us in our setup, contact lens is very, very difficult in terms of hygiene, parental counseling, and all those things. So now, how to reduce the inflammations? We can do less manipulations of the iris. If there is a poor dilatation, use adrenaline or the dilating drops, but less use of pupillary stretch. Gentle synecholysis, capsular polishing helps a lot. Cleaning of the viscoelastics, very good cleaning, and intraoperative corticosteroid like triamcinolone, dexamethasone can be used. And endophthalmitis, if there is an endophthalmitis case and if the intravitreal injections only were given, then cataract can be the possibility. But if it is lensectomy, vitrectomy was then there is an aphakic state and we have to put secondary IOLs. And so in these situations, we have to wait at least 3 months post endophthalmitis state to do the interventions, either to do surgery cataract or to put in secondary IOL implantations. And of course, topical and oral corticosteroids has to be given. Now, these are the conditions that I talked about are some of the special conditions where inflammation is more. But sometimes even with the regular cataract surgeries, after the cataract, it is always in the state of inflammation. So what we do is we do the corticosteroid therapy, and then with a very cautious tapering dose, and cycloplasics are always used, and antibiotics along with that. And usually third to fourth postoperative days, so it is not seen in the first postoperative day, but later on the inflammation parameters increases in the anterior chamber. So this is the day, fourth to fifth or from third to fifth postoperative days are very, very important, and then follow-up should be done accordingly. Another very difficult situation sometimes we get is the toxic anterior segment syndrome, in which it's very difficult to deal with. We have to give corticosteroid and intravitreal the subconjunctival injections, and and when the child is small, it's very difficult. It has to put the child under GA for all these injections, and also it has to be dealt with very cautiously. And so there are different studies which have shown very good results with the implantation, intravitreal dexamethasone implantations. And then another one is a diflu prednate topical versus the prednisolone. So there are some of the things that can be used to reduce the inflammations, like intravitreal implants or any other, apart from the prednisolone, other drops. And then another one is either tricot subtenon, which many of the practitioners use, tricot intracameral or triamcinolone subtenon. So the studies have shown that subtenon is also as good as the other ones, but the one thing, in fact better one, but we have to deal with the increased intraocular pressure. That is very important, and we have to be very careful on that. And one very interesting that is that study was done by my mentor, Dr. Ed Wilson, and there was an insert, the dexamethasone insert, that is Dexena in the pediatric cataract surgery, that is intracanalicular, which has also shown that there is a very less use or no use of post-operative topical drops after the pediatric cataract surgery. This is a very interesting study, but it's still not widely used. So these are some of the things that we have to be careful whenever we deal with either normal pediatric cataract surgery or the high-risk pediatric cataract surgery. So I just wanted to show a video in which if you don't do at the time of repair the good lens cleaning or the lens removal in the perforating eye injury, then you have to land up with this type of situations where there is very severe reactions and severe fibrosis, and it's very difficult to put intraocular lenses also, and we have to deal with the membranes and fibrotic tissues after that. So I removed the sutures in this case at the time, and then the only thing that I could do was to remove those membranes and leave the child aphakic, and then later do the visual rehabilitations. So even the contact lens is very difficult in these situations, and where to put IOL is a very difficult thing to do so. And then another thing, this is an inflammatory cataract. So even the pupils are small. If you remove the synechia properly, then there is no need to use pupillary stretch, because I use very less pupillary stretch during the pediatric cataract surgery. And then most of the time, if you remove the synechia, you can have a very good dilatation of pupil, at least good enough to do your pediatric cataract surgery and then put IOL and all those things. So there is you can just avoid the pupillar stretch in these situations. And then another one is another inflammatory cataract post-traumatic inflammations, and then we have to remove with the vitrectomy cutter. So most of the cataract surgeries that I do is by manual vitrectomy. Even the anterior capsulotomy, posterior capsulotomy, everything I do with a vitrectomy cutter. So thank you so much for your attention. And again, also I would like to invite you all for our annual conference in Nepal in November. You all are welcome for that. Thank you so much.
Thank you, Dr. Srijana, for excellent keynote address on dealing with the inflammation during cataract surgery. I think there is no discussion on the subject, but I can say, in addition to what you said, now presently for the last, I think, 3-4 months, there is a TAS. There is some viscoelastic which is producing TAS. So we have to stop such viscoelastic.
Yes.
That is coming up, it is producing intense inflammation.
Yes. TAS is a very difficult these days. Even for last few months, we are having that. So
I think
yes.
there is a viscoelastic which is producing TAS.
Okay.
So, and
we are-
it is producing even hypopion.
yes.
And they are treating it just like endophthalmitis.